mentioned, I'm Bill Abraham from The Ohio State University, and I'm joined by Dan Ben-Simone from the Moses Cone Health System, and we're really very pleased to discuss with you this evening ReDS technology, changing the world of heart failure. Could we go to the next slide, Elad? I think you're all familiar with Sensible Medical, which is based in Israel and has an office in New York City and a national technical support center. Their primary product, the ReDS technology, is cleared for marketing in the U.S., and it consists of a proprietary medical radar monitoring and imaging technology called the ReDS technology, which I'll just briefly reintroduce to you. I think most of you know about it already, and then we're going to look at some of the to support its use in some of the use case scenarios, which are proving to be really quite effective in reducing the risk of heart failure hospitalization. Let's go to the next slide. So this is the ReDS technology. It was derived from military through-the-wall radar-based technology. It has been miniaturized and put into a wearable vest, and it provides direct and quantitative lung fluid monitoring. And as mentioned, it's cleared for marketing in the U.S. And also in the European Union. Next slide. So what does it measure? It provides a direct and absolute measurement of fluid in the lungs. So the measurement is actionable. This is in contrast to other technologies which have attempted to assess congestion or lung fluid, but could only do so by providing relative measures of lung wetness or dryness. We know from studies done using the gold standard of computed tomography, as well as using the validated ReDS technology, that the normal lung is comprised of about 20 to 35% fluid. So that defines the normal target range for heart failure therapy: a normally dry lung, a lung that is not too wet or too dry. And again, as mentioned, this has been FDA cleared and CE marked. Next slide. So let's review the clinical evidence that supports the use of ReDS technology in monitoring and managing heart failure patients. As you can see here, built on this pyramid, there are really 4 layers of clinical data that are available to support its use. At the base of the pyramid, of course, is the accuracy data, the ReDS CT trial, which compared the ReDS to the gold standard of computed tomography for evaluating fluid content in a tissue, in this case in the lung. The clinical outcome study, the ReDS HF trial, a hemodynamic study called ReDS PCWP, which compared ReDS measurements to invasive hemodynamic assessment, particularly to the pulmonary capillary wedge pressure. And then we'll describe some real-life scenarios, point-of-care scenarios, which really confirm the utility of ReDS measurement for monitoring and managing heart failure patients. Next slide. So the first of these layers of evidence is the ReDS CT study, which provided evidence of the accuracy of the ReDS measurement for evaluating lung fluid content. There are 358 data points shown on this figure. And again, most of what I'm going to show you over the next few slides has been published, and those references can be made available to you. The links to the references are at the bottom of the slides. But 358 data points from phantoms, from animals, and from humans. And you can see that there is a impressive correlation between ReDS measurement and the gold standard CT measurement of lung fluid content with an interclass correlation coefficient of 0.9. Next slide. Moving up the levels of the pyramid, the next slide shows the primary results of the ReDS HF style, a trial which evaluated ReDS guided management in a home use case scenario, and demonstrated that ReDS guided management significantly reduced the number of heart failure hospitalizations. This study was divided into 3 phases: a pre-ReDS phase, a ReDS phase following discharge from the hospital, and a post-ReDS phase after the ReDS technology was removed from the patient's home. And you can see that from pre-ReDS to active ReDS management, there was an 87% reduction in the rate of heart failure hospitalization, and after ReDS was taken out of the home, a 78% increase. Next slide. And here are the results of the ReDS PCWP, the pulmonary capillary wedge pressure comparison, which demonstrate really excellent comparison between hemodynamics and lung fluid content measured using ReDS technology, with a sensitivity of 91%, a specificity of 77%, and a negative predictive value of 95% for a pulmonary capillary wedge pressure greater than or equal to 18. You can see on the right-hand side how ReDS performed with various forms of heart failure, biventricular failure, LV failure, right heart failure, and in normal subjects. And in normal subjects and those with right ventricular failure, the ReDS value fall within the normal range between 20 and 35%. And in patients with LV failure and biventricular failure undergoing hemodynamic assessment, you can see the ReDS values were elevated, compatible with an increase in wedge pressure and an increase in lung fluid content. Next slide. So this brings us now to the top of the pyramid, layer 4, which is real life use results. And there have been multiple use case scenarios across the continuum of care, which have been evaluated or under active evaluation. I have to tell you that after having been pretty invested in the home use case scenario, I've been impressed by the point of care use case scenarios and the ability of point of care ReDS use to keep patients out of the hospital. And we are going to review the data, most of it presented recently at the Heart Failure Society of America meeting. But as you can see on this slide, there are a variety of use case scenarios, including in the home, either in an ongoing fashion or as a point of care test in the home, in the nursing home, in the emergency department, in the observation unit, in the inpatient setting, and in the outpatient clinic setting. Next slide. So with that, I'd like to introduce Dan Ben-Simone, who is director of the Cone Health Advanced Heart Failure Clinic, to tell you about his experience with point of care testing with the ReDS technology, and review with you the data that he recently presented at the HFSA. Dan?
Yeah, hey, Bill. Thank you. Thanks for that. That was a wonderful introduction. And good evening, everybody. Bill, congratulations on your Buckeyes win this weekend. Quite impressive.
Thanks.
Yeah. So once again, good evening, everybody. I'm, as Bill said, Dan Ben-Simone. I am the Advanced Heart Failure Director here at Moses Cone Hospital. As you can see from the slide that we put up, we are in the center of a 6-hospital program in central North Carolina. We're also part of the Triad Healthcare Network, which is a very large ACO. It says 40,000 patients there. We're now up to 80,000 patients. And we're also in the middle of multiple satellite hospitals that we have relationships with, albeit not directly in our system, but help them with their heart failure metrics and try to supply backup care for them. So we've been now using the ReDS technology for about 2 years. And what we've really tried to use the vest to do is be a better partner to systems within our health system. How do we reach out and help these other programs that may not have a formalized heart failure program, but are struggling with heart failure readmissions, are struggling to keep the cost down in their ACO? How do we help improve the heart failure care at those centers and across the continuum of care? So we have several point of care trials that we've done, and we're going to share them with you a little bit tonight. Alad, if you'll go to the next slide. So some of the questions that when we started using the ReDS technology that we wanted to answer, the first question is, we all sort of felt, based on the HERE registry and clinical experience, that many patients get discharged from the hospital after an acute heart failure event while they still may be incompletely decongested. And we thought this might be one of the reasons for an elevated readmission rate. So we wanted to address the fact, could we do a better job at discharge in preparing these patients for discharge and their journey back into the community? You know, there had been, as Bill pointed out, there had been good data already looking at the home use of this vest on a one patient, one vest sort of approach. So the patient got discharged from the hospital, went home with the vest, and as Bill showed, a remarkable 87% reduction in readmissions in that group. And we thought about, could we use a vest in a little bit more broad way? Could we use a vest where we equipped a nurse or a paramedic or a clinic with a vest where we could take care of multiple patients with one vest? And then we also wanted to know is, could the ReDS technology prevent an admission once symptoms began? So a patient called complaining about being dyspneic or orthopneic, and we put a ReDS system on there and we got a reading. Could we act on that and then prevent, would it be early enough to prevent a readmission or an admission at that point? So we thought about a lot of ideas about how we could approach this problem, and then we designed protocols around that. So as you see the slide, thank you, Alad. You see the slide here. This was our first, this is a single center randomized clinical trial at our site. This was a discharge trial. So what we did is we took consecutive patients admitted either to the general cardiology service, the hospital service, or an internal medicine teaching service. And when those patients were admitted, they were then diuresed. And at the time of discharge, when the hospital team thought they were ready for discharge, they were then enrolled into the trial. They were enrolled of one of two arms. Everybody got a reading, and then one arm was a ReDS intervention arm, and the other arm was a ReDS usual care arm. So the primary team said the patient's ready for discharge. One of our nurse navigators or research nurses would go to the bedside, randomize the patient, and then take a ReDS reading. If the ReDS reading was 39% or greater, we would consider them inadequately decongested, and a heart failure specialist, a heart failure consult would be required prior to discharge. In the usual care arm, what then happened is that that reading went up into the cloud, we were blinded to it, and the patient got discharged as planned. So what we found out, if you look at the trial results, we're just still processing the data. We finished just a month or two ago. What we'll see is something we weren't surprised to find out is that 33% of patients in both arms of the trial were being discharged inadequately decongested. So 1/3 of patients had a ReDS reading of 39% or greater. As Bill pointed out, the target range is 20 to 35%. So we gave them a little buffer. We left the people 36 to 38 alone and said, okay, if it's 39, then we're going to do something. In the patients that the heart failure team was consulted on average, we kept the patients an extra 2 days and removed about 5 to 7 extra pounds of fluid in this cohort. There was no worsening renal function in that group. Next slide, please. I'm going to actually, Alad, can you go back one slide? We have a little bit more data now. We've processed in the discharge arm. We have some readmission data now that we are starting to accumulate. If you look at the readmission data for the high group, so if there was a high ReDS group and there was a high blinded group, in the high ReDS group, so those who had a measurement of 39% or greater, we kept a couple of days extra to further diurese them. In 90 days, we had 1 readmission in that group. I think the N in that group was about 17. In the high group that was blinded, they turned out to have 4 readmissions in 90 days. So went basically from a 5% readmission. The N on that group, I think, was 18 or 19. So we went from a readmission rate of 5% to about 23% in the usual care group, which not too far from baseline. So we not only showed that we could safely decongest these patients, but also have an effect on readmissions at 90 days. Okay, next slide, please. We then also used the vest in our clinic. We have 2 physicians in our clinic, a nurse practitioner, a pharmacist, and a physician's assistant. So there's 5 providers in the clinic, and we wanted to see how good the vest measured up to our readings, so the clinical impression from the providers. So over the course of about 6 months, we measured 200 patients, and what we saw is, and this number is actually incorrect, what we saw is that 42% of the patients walking into the heart failure clinic had a ReDS reading greater than 36. 23% actually had a ReDS reading of 40% or greater. So 40% of patients actually who walked into the clinic were significantly volume overloaded. The heart failure provider, we sort of categorized how close we were on or within one category. We said we correlated with the technology, and about almost 80% of the time, our provider assessment and the vest agreed. Next slide. We also use the vest. We have a couple of nursing homes, like I'm sure most of you do, that have a fairly high rate of readmission from the nursing home. They're a little bit short-staffed at night. Patients get short of breath in the nursing home, and they're fairly quick to send those patients to the emergency room. So there was a couple of centers we had locally that really had some significant readmission rates. So what we did is we took the ReDS technology, took a vest to each of the nursing homes, and we used it in 2 ways. The first thing we did is we incorporated the readings into a Monday, Wednesday, Friday vital. So when they got their vital signs on Monday, Wednesday, and Friday, they would get a vest reading as well. And then we also used it for symptomatic. So if the patient called out and said, "I'm short of breath," then the nurse or the nurse assist would go and put a vest on them and give us a reading. So we also formed a diuretic protocol for them. So if they had a certain number, if their vest reading was 38 or 39%, the nurse could go to the diuretic protocol, said, for this number, you'd give this much extra Lasix, this much extra potassium, and then the diuretic protocol would have a follow-up the next day of getting labs, whatever it might be. If the patient normalized, they would exit the diuretic protocol. If the patient stayed the same or escalated, then they would go to the next step of the diuretic protocol. So if you look at the results in 6 months, and the busiest nursing home in 6 months, 10 patients had readings of greater than 35% and were successfully treated. The physician at the site said this has really become the 4th vital sign for their heart failure patients that they look at. More importantly, for the physicians who are on call at night, what happened is that now when the nurses at night or the nurse assist at night said so-and-so is short of breath, they have an actionable number. So instead of just getting an open-ended description, they would get so-and-so is short of breath, and their ReDS reading is 38% or 45%. Someone who's 38%, they would enter the ReDS protocol. Someone who's 45% or 50% then would be appropriately triaged to the emergency room. So we had several patients fall into the sort of middle category. We were able to treat them and able to keep them on site. And there was an assumed up to $100,000 savings based on these 10 patients over 6 months. I suspect the real numbers is somewhere between 50 and 100, but in the best case scenario, we have labeled 100,000 there. Next slide, please. We are now doing another randomized trial in one of our emergency rooms at a sister hospital. We have a sister hospital that's about 20 miles down the road from us. They have a fairly busy ER with a very high rate of admission of heart failure patients from the emergency room. About 85% of patients who present with a history of heart failure who present to the emergency room with symptoms of heart failure will get admitted. What we tried to do is we tried to stratify that a little bit more closely in an effort to perhaps get this. We thought we'd get the readmission rate down to the 50 to 60% range. It would be a big win for our accountable care organization, for the patients, and also for the hospital. The hospital historically has gotten numerous heart failure readmission penalties, and it's looking for ways to reduce that. So we saw this sort of as the final common pathway. If we could attack the problem in the emergency room, really head it off at the pass. So we developed a protocol, as you see here, when the patient comes in with signs and symptoms of heart failure. They get their chest x-ray, they get their BNP, they get the normal workup. While they're waiting for the labs and other things to result, the nurse goes in, puts a ReDS vest on them, and gets a vest reading that she then turns over to the ER physician to help incorporate to their decision-making process. If there's 35% or less, we suggest the lung volume is low, lung water volume is low. We suggest that this is probably not heart failure. Look for other reasons for these symptoms. If they're more in a mid-range number of 35 to 39% lung water, you probably have a mild to moderate heart failure exacerbation here. We suggest 1 or 2 doses of IV Lasix, and then discharge with follow-up in the heart failure clinic within the first couple of days. And then finally, if you have volume greater than 40% or greater than 45%, we initially start with 40, we've now bumped it up a little bit more. Then if they're significantly volume overloaded, we would suggest admitting that patient for inpatient management and further IV diuresis. Interesting, one of the first patients enrolled in the trial, they were getting comfortable with it. The patient had a reading of 52%. They got 1 dose of Lasix. The ER physician asked the patient what their preference was, if they wanted to go home or stay in the hospital. The patient decided to go home. About 2 hours later, represented to the hospital in fluid respiratory distress on BiPAP, and nearly got intubated. So we would argue in that point that patient was inappropriately discharged from the hospital when they could have used the data at hand to really triage that patient better. And I think for this case is really where, particularly in the ER, the ReDS technology really outperforms the BNP. People can have different levels of baseline BNP. When it comes to the ReDS vest, you get a really an accurate picture of how much water is in the lungs and can really help guide clinical decision-making at the point of care of how aggressive you're going to be at that moment. Next slide, please. So this is the last point of care case scenario, and probably our most effective to date. What we have is, this is a hospital. It's about 35 miles south of us. They're a satellite hospital. They're not part of our network, but they have struggled with very high heart failure readmission rates for over 5 years. And really have tried to get physician buy-in to tackle this problem, but really have not had physician buy-in locally. But they had a very dedicated home health nursing program that was owned by the hospital and needed to be engaged to really make a difference. So we sat down, we had a few meetings with them, and they were looking for a way to better triage these patients, and once they triage them, and then to act on them. So we sat down with them. We got them a vest, and we once again gave them a diuretic protocol to be used with this patient population. So there were 3 home health nurses, and we took patients who were recently discharged from the hospital with heart failure. And when those patients went home, they got a home visit from that home health nurse, and they got a baseline ReDS reading. And then they got a reading anytime they called the nurse. The nurse would come out to their home and get another reading on them. So we had 51 patients. It's now up to 53, but we had 51 patients at the time into the protocol. And you can say of those 51 patients, 15 of those patients, so about a third of the patients, actually had elevated readings and entered the diuretic protocol at some point during these, it's about 6 months, during the 6-month period. And some patients actually, some of these patients actually dipped into the protocol several times. And what we found with that patient population is that we not only were able to tell how wet they were, but we were also able to hone their diuretic regimen. You know, we had one patient who was 102 years old. He had several heart failure hospitalizations, believe it or not. He got discharged on 20 of PO Lasix because everybody was nervous to give this older gentleman more Lasix. After a couple of weeks in the protocol, he stabilized very nicely on Lasix 80 BID and shown it was safe to do it. We kept his lung water down, and we were able to keep him out of the hospital. So we went about 6 months with 50 patients, and within that cohort, we had 0 rehospitalizations within that 50-patient cohort over 6 months. And this number, 23 to 8%, is actually the heart failure hospitalizations. If you look for heart failure to all cause, it was actually 25% to 15% in this population, and there was no readmissions. There was no heart failure penalty, and I should say for the last year. So there was no heart failure penalty incurred for the last year for this hospital for the first time since the penalties came. So a very successful project here with this hospital system, one that we think we can reproduce with other hospital systems surrounding us. And probably the most important part for us is that we were able to help them with these 50-some patients, and we never actually told them to bring a patient to our clinic. So we actually never saw one of these patients in our clinic. We were able to manage them through the nurses remotely, really developing a heart failure program for them using the technology, engaged nurses, and the backup from our heart failure program remotely. So a very successful thing, and one that we're looking to duplicate among several other hospitals in our network. So I guess a quick wrap up here. Are we discharging heart failure patients from the hospital who still have fluid in their lungs? I think we all know the answer to that. Scope of the problem being about 30 to 35% of people are probably going home still inadequately decongested. Can this device be utilized for individual patients at various points of care? Certainly we can do that, and I think there are multiple other uses that we can find as well. Can the vest prevent an admission once symptoms have begun? Most certainly. And can we keep patients out of the hospital by utilizing this technology? And I think the experience at our center and multiple other centers, as you'll see, we've been seeing about, on average, a 70% readmission, a reduction in readmissions in patients who use the vest at point of care settings than patients who are treated with usual care. I think I'm going to turn it back. Next slide, please. So here's a little bit of the ROI. We bought 4 vests initially, $100,000 initial investment. We think that we probably had 25, and I think these are all conservative numbers. 25 assumed avoided admissions at $10,000 each was a $250,000 savings. The hospital in Randolph, where he had those 50 patients and got them out of the penalty, they assumed they saved almost $800,000 in penalties for the time period. We think that discharge using the ReDS vest can really help identify high-risk patients who are able to be followed in the heart failure clinic. And finally, at Moses Cone, we've been very aggressive at reducing our readmission rate. We consistently now run a readmission rate of 14 to 15%, and we think this technology is just one more piece of the puzzle to help us keep the readmission rate down. Obviously, readmissions are complicated and multifactorial, and this is just one more piece of the puzzle.
All right, thanks, Dan. Fabulous presentation, and just fabulous data. You have studied multiple point-of-care use case scenarios and demonstrated with each of them significant reductions in heart failure readmissions and cost. And I think we'll continue on that theme. I'm going to move through some data relatively quickly. Unfortunately, neither Sean Penny nor Sanjay Dhanamani could join us this evening, so I'm going to share some of their data with you. But again, I'll go through it quickly because it continues on the theme that Dan's presented. In this case, the Mount Sinai experience, Sean Penny's experience, was utilizing ReDS in a rapid follow-up clinic program. So this was in-clinic utilization of the ReDS technology. And as I'll show you in a moment, while these patients get a relatively rapid clinical assessment that includes weights and vital signs and symptoms and so on and so forth, Sean really has begun to manage these patients to ReDS values. And this theme that we've been 70-75% reductions in heart failure hospitalizations with point of care use of ReDS, is seen again in this study. So let's go to the next slide, please. So as mentioned, the guidelines for use was to include this as part of the patient assessment, which included vital signs, ECG, laboratory data, signs, symptoms, and then a ReDS reading. And very simple algorithm based on what we know about ReDS and the normal value for a normally dry lung. So if the ReDS was less than 20%, the diuretics were reduced. If it was greater than 35%, the diuretics were increased. And if it was in between 20 and 35%, the current diuretic regimen was continued, and the clinician was instructed to look for opportunities to optimize neurohormonal antagonists. And then there was a documentation of the encounter, the ReDS follow-up in the note. Next slide. So increasing diuretics, the protocol was to double the dosage for 3 days or longer, depending on how wet the lungs seem to be, to reassess within 1 to 2 weeks with another ReDS reading, and then to follow the following protocol. If back to baseline, resume the previous diuretic dose. If still above baseline or out of range, increase the dose or add metolazone, and continue to closely follow electrolytes and renal function. Next slide. So this is the early experience from Sean Penny. Just started using this point of care testing with ReDS in July of this year, but reported the experience with the first 28 patients, followed in the rapid follow-up clinic at 7 and 30 days post-discharge, and demonstrated a 70% reduction in the 30-day heart failure-related readmissions. Heart failure-related readmissions dropped from 12% to 3.5%. 16 patients had their medication adjusted to meet the ReDS results. So 16 of the 28 patients required active ReDS-guided management, and this certainly contributed to the 70% reduction in heart failure-related readmissions. Next slide. So here's just one patient example, a 45-year-old man with a very low ejection fraction, chronic kidney disease, 6 hospitalizations in the year prior to this index event. You can see that initially the ReDS value was very high at about 45%. And so the patient was given furosemide at 80 milligrams twice a day. You can see then a few days later, the ReDS value was still elevated at about 38%, and the furosemide dose was increased, was doubled, and then the patient came back down towards the normal range. And Sean made these slides, so I'm not quite sure what he did with the diuretic on that third point there, but I suspect by then he's starting to back off of the higher dose. Next slide. So the early observations from Penny's experience was that this was easy to deploy. Took about 3 minutes to size, fit, and make a ReDS recording. Patients liked the immediate feedback. and it was not disruptive to the workflow. The reasons for not using REDS were a couple of patients whose BMIs were too high or too low to fit the vest, patients who had a Hickman or permacath on the right side of the chest that interfered with placement of the vest, or who were wearing a life vest, or patients who refused, or patients who were in for a study visit rather than routine clinical care. Next slide. So Sean's planned next steps are to continue to compare REDS to standard of care in a larger cohort, and to look at its effects on more prolonged readmission rates, not only at 30 days, but out to 180 days, and to continue to examine the medication changes, which are driven by REDS measurements, and understand their impact on reducing the risk of heart failure hospitalization. Next slide. Now, the other experience that was reported at the Heart Failure Society meeting last month came from the Geisinger Health System in Pennsylvania, presented by Sanjay Dadamani, who runs their advanced heart failure program. Go ahead forward. That's fine. And essentially, they've come up with a protocol for evaluating patients at the time of discharge into various groups, those who, are sort of still, in crisis, those at high risk, those at low risk for readmission. And go ahead to the next slide. I'm sorry, I do want to have time for discussion, so I'm going to move through this relatively quickly. But go ahead to the next slide, please. And essentially, they implemented a workflow that is shown on this particular slide, using a hospital-to-home transition that employed a heart failure nurse navigator who was really based within the hospital, by using both community and specialty care case managers. But importantly, they used a community health assistant to go out to patients' homes and do point-of-care assessment in the home of REDS measurement. And it's important to note that these community health assistants were not healthcare professionals per se. They had no more than a high school graduation, but they were trained to go into the home, complete a relatively brief symptom-based survey of the patient, to do basic vital signs, and importantly, to take a REDS measurement. Next slide. And so the protocol that Dadamani implemented is shown on this slide. He actually defined several different groups here rather than just high, normal, and low. He had optimal volume status, which is sort of the middle of that sweet spot of 25 to 35%, low normal, low normal, possibly high, definitely high hypervolemic status, and then extreme volume overload. And you can see the ranges defined here on the gauge for how he defined those. So, the goal was really to keep patients in the green zone, to begin to respond if they went into these yellow zones. And of course, if patients went into any of the red zones, this would require more aggressive therapy. But the goal here was to implement all of that therapy in the patient home rather than readmitting them to the hospital. Next slide. So here's what Dadamani was able to show, and maybe you can click through that so the rest of the text comes on the left side of the slide. Perfect, thank you. So you can see that to date, or at least as reported at the HFSA, 28 high-risk or crisis patients were included in this cohort. 46% of patients had been hospitalized 30 days prior to enrollment, some on multiple occasions. REDS technology was used to assess volume status and correlate symptoms in order to reduce readmissions. 86% of these patients were successfully treated in the home, avoiding a readmission. You can see the data on the graph on the right-hand side of the slide. comparing the 30 days prior to REDS to the 30 days with REDS, demonstrating a 75% reduction in heart failure readmissions. Next slide. And I think for time's sake, why don't we go ahead and skip the cases here. You know, they're similar to the earlier ones. I think they each have a different point, but I want to try to get to the conclusion of the formal presentation to give you some time for your comments and questions. This slide shows a return on investment calculator that Sensible Medical has developed, which will allow you to calculate what the potential savings are implementing ReDS point of care technology in your institution or health system. Next slide. And this slide briefly summarizes the ReDS implementation process. I know some of you have some experience with ReDS, perhaps others have little or no experience with ReDS, but suffice it to say that Sensible Medical has a program of support to get you up and running, from project planning to clinical staff training to ReDS system certification to going live with your clinical program and analyzing your outcomes. It's certainly you know, well within your reach to replicate the types of improvements in clinical outcomes, the type of results that you've heard about from Dan Ben-Simone and seen from Sean Pinney and Sanjay Dadamani. Next slide. So in terms of getting a program started, I think one of the things we've learned through many experiences is that it's important to identify a champion, a physician champion, a nurse or a nurse practitioner, or someone else that's part of the multidisciplinary heart failure team at your institution to champion the utilization of ReDS, to learn from the experience of ReDS excellence centers such as Geisinger and Mount Sinai and the Moses Cone system. You can also become part of these centers of excellence by becoming one of the leading heart failure centers to utilize ReDS technology. We are in the process of planning a large ReDS point of care registry, and would love you to participate in that as well, so we can continue to gather data and better understand the benefits of point of care testing with ReDS technology. Also, Sensible is very amenable to investigator-initiated studies. So if you have some ideas about how you would like to study this on your own at your institution, please talk to your Sensible Medical representatives about that. Next slide. Based on what you've seen this evening, you know, I think it's become apparent that the point of care use of ReDS produces improvements in clinical outcomes that are similar to that seen in the ReDS HF study of the home utilization of ReDS technology, and perhaps far more cost effective because you only have to invest in a small number of devices to have in your clinic or your hospital or nursing home, or to deploy as point of care testing in the home or the emergency department, rather than the one vest, one patient approach that you heard about earlier. Next slide. I did want to announce, because I think this was just announced today, that Sensible has a new medical director who I think many of you know, Dan Burkhoff, is assuming the position of Sensible Medical Director, and he brings significant experience from the scientific, academic, and real-world clinical practice, as well as industry perspective. Dan is based at the Cardiovascular Research Foundation, the CRF, but is also serving as medical director for Sensible, and will be an incredible resource to you as you get more and more involved with the ReDS technology. Next slide. And that's it. Thank you for joining the ReDS webinar. Together we can change the way heart failure patients are managed. I want to thank you for joining the call tonight, and we're going to open up the lines. Please unmute yourself if you're muted, if you have a comment or question, and Dan's available as well.
There are direct references to this.
I'm sorry, is someone trying to make a comment? Dan, while we wait for folks to formulate questions, any other thoughts or comments?
No. Yeah. So, you know, we've been very involved with this over the really, it's almost been 2 years now. And, you know, what I try to stress in our program is that, you know, at our core center, we have a very active and very, very good heart failure program. But I think where the technology has really helped us is in two ways. It's really let us spread our wings. So we've been very involved with trying to help. We now have a tool where we can reach out and help our community. We give them a tool, we get actionable data, and we are able to turn providers who may not be the most comfortable with heart failure assessments, let them make the heart failure assessment using the technology, and then give them a protocol right behind it to make change. So I think the 2 points is, one, it lets us spread our wings without using more resources from our heart failure program at the home site. And the second thing I think it allows is it creates actionable data. We now take providers, for example, some of our pharmacists at outside hospitals, some of our very engaged home health nurses at our outside programs who want to be involved and want to help these patients, but are limited by some diagnostic challenges. Now they have a tool where they get over that diagnostic challenge and they can do what they can to help these patients. And it's just been phenomenal at elevating the ability of these secondary providers to provide care to these patients. And so we jokingly, you know, commented that we now have an army of heart failure providers marching around our region, you know, armed with a new weapon. And it's really been, we've had some great meetings and a lot of community engagement around it. So it's really been a great experience for us.
Oh, those are very good points, Dan. And you know, I think you're right. Essentially, this takes the guesswork out of patient assessment. I mean, we know even in the hands of heart failure specialists, it's just tough to evaluate volume status, and particular lung fluid content, and you know, we kind of make our best guess at it. You know, I think the observations that you know, patients that are coming to clinic that we think are doing pretty well have elevated ReDS values, and you know, that observation is consistent with what we saw with some of the hemodynamic monitoring studies, where, you know, in the Champion trial, for example, you know, 50% of patients who were thought to be compensated at the time of their implantable hemodynamic monitor procedure, you know, had pulmonary capillary wedge pressures above 18 or 20. So, and some of them were as high as 30 or 40. So it's really difficult, you know, to make this assessment clinically, and the ReDS takes the guesswork out. Questions, comments from the participants?
There is one question in the chat.
Yeah.
How comparable is ReDS data to getting routine BNP?
Yeah, so you know, I can say that I'm not aware that there have been any direct correlations yet done between BNP and ReDS. If anyone else on the line knows of them, or Dan, if you've got any experience, let me know. But you know, I don't think the correlation is likely to be very good. I think what we've learned about BNP over the years is that it doesn't correlate very well with hemodynamics or pulmonary capillary wedge pressure, nor is it really very reflective of lung fluid content, and you have to have big changes in BNP values to be indicative of significant changes in hemodynamics. And I think that's why the BNP-guided heart failure trials have really failed. It's a good adjunct to diagnosis of heart failure, and it is a prognostic value, but it really has proven to be of little or no value in guiding heart failure therapy. Dan, any observations?
Yeah, I think that's exactly right. And I think the other thing is, you know, we go out into the home and the patient's complaining of shortness of breath right then. You know, certainly the nurse can go out and grab a BNP, send it back to the lab. We wait a day and figure out what the BNP is. And then we really don't, as you say, then we're further complicated by the fact of poor correlation with lung water. You know, what makes people symptomatic, what drives them to the ER, what drives readmission is lung water. And at the end of the day, what we want to know is, is there fluid in their lungs? And if so, how much is it? It's nice to have a tool that measures that directly instead of a secondary surrogate.
Great. And now that I actually found where the little chat things go up, there looks like there's another question. Is there a minimum and maximum BMI for patients to use ReDS? And the answer is yes, currently. There's ongoing work being done to expand the range. And Alad, can you remind me, is it 35 at the upper end and 18 at the lower? I want to make sure we get those numbers right for the group.
So it's 38.
Yeah.
What is it?
38.
38.
Yeah.
38. Okay.
And then 20 on the lower end.
20 to 38. Okay. Okay. Can pneumonia be incorrectly read as water in the lung? And I'll tell you, and I'll see if Dan has any observations about this or anyone from Sensible does. We don't have a lot of experience yet. With concomitant pneumonia. I think if one had a consolidating pneumonia in the right mid lung field where the ReDS measurement is taken, that it probably would affect the reading. Dan, have you seen this yet or got any experience with it, or anyone from Sensible?
Yeah, so we've seen a bunch of it actually. So yes, we had a couple of patients who were consolidating the right middle lobe, and they do get elevated numbers if it's a left lower lobe pneumonia or something on the other side, then or right upper. We have seen no change. We had one interesting case with someone with very low neck veins, and low BNP, but diffuse infiltrates, very short of breath, acute diffuse infiltrates on X-ray, and we measured them, and their ReDS reading was very high. And it turned out to have acute diffuse pneumonitis. The ReDS vest is what triggered the heart failure consult. It all got figured out that something's wrong here. It's not necessarily fluid, but it's inflammation in its lung. It's not necessarily, high wedge, but it's inflammation in its lung edema from that. And so, yes, it will detect any sort of fluid in the lung if you have a dense infiltrate in the right middle lobe. It will skew your readings, but hopefully you'll correlate it with what you see on chest X-ray, and otherwise it should not be a significant issue.
Yeah, so still a measure of edema, pulmonary edema, just in this case, non-cardiogenic. Okay, exactly. The next question is if the sweet spot reading is 25 to 35, what is the reasoning for some of the example programs choosing 39 or greater for action? So I think a bit of this, relates to just, tailoring to individual patients, just as we learned through our experience with implantable hemodynamic monitoring that while, the normal pressure range is the target range, while the normal, range is the target range, there are always patients who you can't quite get there. They get hypotensive, they get worsening renal function, some other untoward effect. And so in that case, you try to get them as close to that range as possible. And you do have the ability then with the ReDS system, to, on an individual basis, reset the range for them. So, having some patients live a little bit on the higher side. Dan, help us here too?
Yeah, so agreed. So obviously we target, 34, 35, a little lower. There are some people who, just like you said, they are quite comfortable at 36 to 38, do just fine. Just like tolerating a little higher BNP in these people. The reason we chose 39 is people really don't get overly symptomatic until they're in the low 40s. 41, 42, 43, people start getting orthopnea, and that's really when they start developing clinical syndrome, clinical symptoms. So we don't want to keep people in the hospital because their number is 37 or 38. That's manageable as an outpatient. You can continue to try and drive it down into more of the green range as an outpatient. But we like to see people out of the danger zone, out of that 41, 42 range before they get out of the hospital. We just feel it's a little bit of a safety margin. As we develop experience with that, we get a little bit bolder. But, first things first is, as we get comfortable with the technology, we want to ensure that patients are safe and we're not putting anybody at risk. And it's really outperformed expectations. The clarity with which we can drill down on these numbers has really been quite remarkable.
Great. So the next question is, does change in position confuse the picture? It's an interesting question because early on, as ReDS was being developed, we did do a series of studies where we took measurements with patients in a supine position, sitting up, legs up, different maneuvers that would centralize blood volume in patients, and you can detect changes in centralization of blood volume with posture change. So that's why we try to make these ReDS measurements in the same position, generally in the clinic or even in home utilization. We do them with the patient sitting up. The next question is, what's more important, the more important clinical target, PA pressure or lung water? Well, I think many of you on the line know I'm an enthusiast around implantable hemodynamic monitors as well. And I think the bottom line is that, absolute measure of PA pressure or absolute measure of lung water, both give you, similar and similarly actionable information. The lung water measurement may actually give be a little bit more informative in regard to, what you're seeing, both combined with the intravascular volume expansion as well as the interstitial fluid excess in the lung compared to pressure. But I think both are informative. You can manage to either PA pressure or to lung water as long as you're getting an absolute measurement of lung water. This is why transthoracic and intrathoracic impedance fell down. But if you have an absolute measurement of lung water, you can use it in the same way that you would a PA pressure sensor. Not every patient is going to have an indication to have an implantable pressure sensor. And certainly for these point of care use case scenarios, point of care assessment of PA pressure requires taking the patient to the cath lab to do a right heart catheterization, where you can get, informative information doing a ReDS measurement of lung fluid content in the clinic. Dan, any thoughts about that one?
No, I think they're both useful. We've used both, and for us, within the heart failure clinic, I think CardioMEMS is a good tool where we're able to follow within the heart failure clinic. One thing I would like to see out of the CardioMEMS device at some point is that the patient's able to see their own numbers, so they understand they can change the behavior and kind of correlate with symptoms. But I think you pointed out the really most important point is that for a point of care use, this is something you can take at any site. Can put it on anybody, as long as they fit the size, put it on any patient right at point of care and get a reading and train patients to be used to that reading. So I think they both have their pluses and minuses, but for the way we've designed our outreach to our community, it can really only be done with a device that's portable and able to provide point of care information.
Great. Well, I think we are out of questions, and it looks like we're out of time too. So I again want to thank everyone for joining us this evening. And you can find me at the Ohio State University and Dan at Moses Cone. And please, if you have questions, at any time, please feel free to reach out to us. And I hope you all join us in gaining some experience with the ReDS technology. Thank you again, and good night.